folks. We're going to give it a moment or two for folks to join. We're glad that you're with us today. If you'd like to introduce yourself in the chat, we would welcome that. This is a heavy topic, an important topic, and certainly it's always valuable to hear where you're coming from, your roles, and anything you'd like to get out of the session today. So I encourage you to do that. While we wait just another moment for folks to join us, do just want to note that this is a webinar format, so lines are muted, but we would love for you to share your thoughts, ask your questions by using the Q&A feature, the chat box. And thank you, Kim, for kicking us off with introductions in the chat. All right, so as folks are continuing to join, for the sake of time, we can go ahead and get started. So want to say again, hello and welcome to our webinar focused on suicide in older adults, what you need to know about risk and prevention. So this is a webinar from the National Center for Equitable Care for Elders. My name is Ariel and I am the program manager of our center. We're very glad again that you are all joining us today. This session is also being recorded as a resource for those who couldn't make this particular time slot work. Like I mentioned a few moments ago, all lines are muted, but we would love to hear your feedback, have you ask questions, give your insights in the chat box or the Q&A feature. Thank you all who are introducing yourselves in the chat. We will send out the recording and the slides as a resource to all registrants after this session. So just stay tuned for that. Don't worry too much about writing things down. We'll make sure you get those as a resource. All right, let's go ahead. All right, so if you are not already familiar with our center, this is just a very quick plug for who we are and what we do. We provide training and technical assistance to health centers across the country who are serving community-dwelling older adults. We provide a variety of live training activities as well as asynchronous modules and downloadable resources. So encourage you, if you haven't already, check out our website and social media handles. We'd love to stay connected and let you know of other learning opportunities that are coming up very soon. All right, so that's a very quick intro. I get to transition right away to our wonderful presenter today. Dr. Peter Miramaldi is one of our center's subject matter experts. You can see on the slide, he is very busy in a variety of academic settings. I'll let him give more insights as far as his background goes, but we are very fortunate to hear from him today. If you have questions or comments, again, for Dr. Miramaldi, feel free to put those in the chat and the Q&A throughout this session, and we will try to get to as many as we can before the end of the hour. So with that, I'll hand it over to you, Dr. Miramaldi. Thank you so much.
Thank you very much, Ariel, and welcome everyone. It's a pleasure to be here. This is a very important topic, and I would just introduce myself in this context, please, while you're reading these learning objectives. What comes to mind when I think about this is the first elder suicide that I experienced personally was a 93-year-old man who was my roommate during the summers in Philadelphia, Pennsylvania. And we lived together as sort of caretakers for a church. It was a way for me as a student to work during the days and get free rent. But when he was 96, my dear friend Ray said to me, it's my birthday next week. It's going to be my last one. And 3 months later, he was dead. And I'm going to be referring to Ray throughout this, but he decided it was he no longer wanted to live when he was 96 years old. My first experience with suicide was a 17-year-old, and my worst experience with suicide was a 13-year-old whose crying, begging mother asked me to cut him down after he hung himself, and I did. Next slide, please, Ariel. And that's why I want to just caution you that in terms of this trauma-informed approach, that I may be referring to things that you will find disturbing or difficult. And for many of us, they may stir up personal experiences for ourselves or loved ones. And I ask that you don't go it alone. And if you could talk to someone, don't suffer alone on these things. You can go to a friend, a relative, a loved one, somebody you trust. And we're going to talk more about the 988 suicide prevention hotline. And there's hosts of other emergency centers around the country. I spent many years of my life volunteering in crisis hotlines. And I saw in the registration that many of you are working in these kinds of facilities, and I have deep admiration and respect for what you're doing. Next slide, please, Ariel. If I get it wrong, tell me, please. This should be an opportunity here for us all to learn from each other. And this is very important, this inclusiveness. Please don't hesitate. You can put it in the chat and our colleagues here will inform me of it, or you can speak out. Next, please. Let's start looking at some numbers. The way to read this is from the Centers for Disease Control and Prevention, CDC. And these are the crude rates, which means they haven't been checked out yet. These are the most recent rates we can see. And you can see the top line is people who are 85 and older. And if you look from the left to the right, the further right it goes, it's the higher the crude rates per 100,000 people. Now, this is small, but this is 22.4 for 85 plus people. 22.4 out of 100,000 people in that age group took their own lives. And it's followed by the next age group was 75 to 84. And it's tied with the 25 to 34-year-olds, roughly. But you can see there's a disproportionate distribution here where older people are more likely to take their lives, which is the focus of this webinar. Next slide, please. The group that is most likely to commit suicide in the United States are non-Hispanic, Native American, Native Indian, and Native Alaskan natives, which is very interesting. And we're back just over a third of all the healthcare expenditures in the United States, which means they're highly likely to land in health centers or facilities that many of you work at. And in these age groups, there's this disproportionate likelihood that people are going to commit suicide. And you can see here the age distributions. The next slide, please. So it may get a little bit confusing, but when I talk about the really high rates in the people 85 and older, it's because of the total suicides, it includes the 2/3 to the left here, but it's the 1/3 to the right that I'll be talking about in the next slide. Next slide, please. So you see here the suicide rates among adults 55 and older by age and sex. So men are on the left. Now, the way to read this slide is the bar graph, the higher it goes, it's the deaths per 100,000. Again, it's the metric that we're using from the CDC. So you can see the total is black. So it's a little bit confusing. But remember, it was that 1/3 on the right. That's where we see the 55.7% in that group, the highest one. And it's the group that's 85 and older. And it's mostly men. And if you compare it to women, you'll see the rates are much lower for women. So that's a very, very high proportion for older people. And in a couple of slides, I hope you can come to understand why it's more likely if you don't already. So if you compare that, you see the rates are between 2001, the blue lines on the graph to the right, and 2021, the most recent data available, or the green lines on the right. The rates are increasing. Why do you think that is? For the most part, we see an increase in the suicide rates among this population. Interestingly, Puerto Rico has lower rates of suicide, but increasing rates of depression, which I found very interesting when I was researching for this presentation. Next slide, please. This is the means of death, the mechanism of death, how people took their lives. And the way to read this chart on the left is that 45, the high line is 45.9 per 100,000 shot themselves with firearms. And again, that's the 85 and older. And the next line to the left, the darker green line, are 75 to 84. So you can see firearms is very high. And the next one over on the chart on the left, this is men, is poisoning, and then it's followed by suffocation, and then all other mechanisms. The bar graph on the right is the suicide, the mechanism for women. And you can see here, firearms is still high, but the poisoning is low. So right now, it's very interesting that firearms is such a prominent means. So one of the things, and this is not a clinical presentation, I'm going to be talking about resources and overviews, but one of the things that's very interesting is the presence of firearms. So when we do safety planning, which is often what a professional counselor will do with a suicidal individual, we'll make sure if there are firearms available to try to get rid of them, to move them someplace, to make them inaccessible. Interestingly, one of my doctoral students right now is doing a study, a brilliant student doing a brilliant study on young people, 20 and younger. And firearms there too is the highest means of the highest mechanism of taking one's life. Next slide, please. So we're going to do a little question, a Mentimeter question here. Ariel, do you want to explain this, please?
Sure. So you can see
Thank
the
you.
QR code on your screen. You can use your phone to scan that. You can also go into a browser and type menti.com, and you can use the code 81090144. I see a little thumbs up in the corner, which is great. Yes, in the chat box, we absolutely will give the slide deck and this recording to all registrants. So we'll give it a moment. I see lots of folks joining. Thank you. If you are having technical difficulties with Mentimeter, feel free to just type your answer to the following prompt in the chat box as well.
So I hope in the preceding slide you saw that, you know, the reason that the NCECE decided to do this webinar is because suicide is a real issue with this population, with older populations. And very often it's a population that gets overlooked when we think about suicide interventions. There's a lot of media coverage now, a lot of press about young people. I also want to say, while you're doing this, I never really trust the statistics. I think we underreport. Very often a suicide will go unreported, like my friend Ray's death. The cause of death was listed as sepsis. It was not listed as suicide, but he clearly killed himself. So this is unfolding nicely. So we're seeing isolation right in the middle. So you agree with the literature, and I think we've done a great job in the public health service in the United States to demonstrate that. Loneliness, isolation, and depression. Very, very interesting. We're still coming here. So I see some of the things I'm seeing here. These are all, you're all very well informed. This is terrific. Poor health, widow or a widower, chronic pain, illness, disease process, mental health, money, financial issues, the access to firearms. Then we may have led you a little bit on that, but absolutely, I think that's pretty common knowledge. And this notion of loss, I see a little one there with loss. That's really very, very important. And we'll talk more about that as well. Very interesting. Okay. Keep them coming, and we may click back to this. But you see the big three in the middle there, absolutely right. The link here is to the Rural Health Hub. Many of you are familiar with this, I'm sure. What's interesting is they talk about, all these links are live as of yesterday. They talk about the highest risk groups to being veterans. That's not just in rural areas. That's every place. Veteran suicides is a big tragedy in this country. And if any of you are working with the Veterans Administration, with the VA healthcare system, you're fully aware of this. It's an issue that really the nation needs to address. Can we go, I don't know which, can we go forward, please?
Yeah, I'm not sure. Let's see. I'm sorry about that. That kind of just
No worries, no worries.
ahead.
So this is an important slide. this notion of what we're going to be talking about. If you're uncomfortable with this situation, to talk with an older person or even a younger person, then again, this isn't clinical, and this is really about countertransference, where as a provider, I'm thinking about or approaching your situation from me more than from you, but try to think about being able to talk with someone about their intent to harm or kill themselves is really good for them, and it may be uncomfortable for me or for you. The idea here is we have, these internalized issues about our own mortality. It's really scary to think that some people might hurt themselves or even kill themselves. Many of us grew up with stigma. I was a young man, I remember if somebody died, they would hide it. I mean, where I live, a woman took her life by jumping in front of a train, and the family took great effort to make that a private issue, which I see as a loss because it's an opportunity to promote public health. 2 nights ago, someone in another town near here, I got a call, took their life with a weapon, with a gun. And the town is trying to suppress that. I think that's a mistake. I think it's very important to be able to talk about these things. The idea here is that if you think that if you're going to talk about suicide with someone, it's going to give them the idea or push them closer, the literature is in pretty much agreement. My own clinical experience is pretty much in agreement. My own experience as a supervisor with people working with suicidal individuals is that that's not the case. It's almost a relief. It's like I'm holding this inside. I'm terrified to talk to anybody. And those of you working in hotlines or intervention centers and crisis centers, I'm sure you've experienced this. It's a relief for the person to be able to talk about it. It lessens that sense of isolation. It's a terrific thing. It's a service that you can do for someone. And sometimes it helps to have scripts prepared in mind. They call these different things in the literature. But if somebody's telling you that they're thinking about hurting themselves, the worst thing in the world, you can say, oh no, don't say that, because that heightens again that sense of isolation. I'm glad you're telling me, let's talk more about it. I want to hear about your thoughts of hurting yourself, of dying. The whole idea here of I care about you and I want to help. If that's sincere, and I think it would be sincere if you're in that situation, I want to help. And, encouraging people, this notion of unconditional positive regard, to be able to talk with someone non-judgmentally. And I hope that I'm going to show you some early work from Schneidman, the person who really started suicidology, that you can see why it's not to be unexpected. Next slide, please. Is there a question here?
Yes,
Okay.
we had a question from Teresa, who is going to write in the chat. And she asked, do you think elders may ever be able to have the option of euthanasia when they wish?
Then you should take a course in medical ethics. I think that I'll tell you about my dear friend Ray. When I learned that he was dying, I knew what he was doing. He stopped eating, and I drove 2 hours to the hospital, and I sort of made a scene. I know my way around hospitals, so I got in after hours, and I demanded to see the attending, and the attending came out, and I said, "Why aren't you, preventing this?" and blah blah. And the physician took me into another room and said, "I've known him since I was a boy, and if he wants to die, I'm going to help him die." And we both cried, and we both went out, and we both kissed Ray on the forehead together and said our goodbyes. So who knows? I think that a lot of this occurs and we don't even know about it. It's beyond the scope of this presentation, but it's something to be aware of. I have studied Emil Durkheim's work extensively, and I think it still has relevance today. But I'm going to focus instead on Schneidman. And Schneidman was really, they call him the father of suicidology. I had the great privilege of studying with Schneidman when I was a young man and learned a lot from him. But he started by doing psychological autopsies. And the way to do, the prominent way to do a psychological autopsy of a suicidal individual is to look at suicide notes. Now, not everybody leaves a suicide note. but that's how he got hooked. And what he discovered, and when he started as a clinician, as a psychologist, when he started talking with suicidal people, he kept in his mind hearing psychological pain, unbearable pain. Just have to get away, escape from this pain. It's like a hand out of the fire. And he came up with this term psych ache, P-S-Y-C-H-A-C-H-E, psych ache, which is a hard word for me. I don't like it. But the thing to think about, to remember, is this notion of severe psychological pain is driving this. And think about this in the context of elders. Next slide, please. So Schneidman had these 7 commonalities after a lifetime of study. Well, he went on a lot longer after this. Linares wrote a good article that's linked here, and that's what this is taken from. I've read all of Schneidman's work after, before, during, and after my study with him. But the idea here is you can read through these, but sometimes people see suicide as a solution. And you have to, and when I'm not going to do the clinical piece here, but it's not the only solution. But the whole idea is that the last number 10 is people have lifelong coping patterns, and sometimes they're self-destructive. Schneidman talked about smoking as being a slow self-annihilation. During the AIDS epidemic, we saw people who were having reckless episodes of sex as a means of self-annihilation. People who don't take care of themselves, it's a means of self-annihilation from Schneidman's view. So the idea here is that if things get really bad enough, all of us can do this. I hope you've had a chance to read through these, those of you who can see the screen. But if you look at number 8, the action of suicide is egression. It's a way to get out from under that unrelenting pain and discomfort that's so just excruciating. And this has helped me. I don't know if it helps you, but I hope it helps you if you're going to be in a situation where someone verbalizes or gestures or suicide, and you'll be able to understand that, yeah, it's not such a terrible, taboo, stigmatized thing. This person's in so much pain. It's the only way they see to get out. And that's this notion of constriction. They don't see any other options. And that's where our clinical colleagues come in, and they help them see those other options. They help them work through that. I'd be happy to talk more about this if any of you have questions, but I'd like to go to the next slide. I know one other thing is this notion of hopelessness. Now, number 5, the people really feel hopeless, and that's a very common. You'll see that, and very often in older people. Next slide, please. This is the future. This is where we're going, and right now we're not there yet, but it's something just to think about. It's the stress diathesis model of suicide. And this is a brain-centric model, and we're still learning so much about neuropsychology. But you can see it tries to combine the environment, the ecology that people live, that Schneidman was talking about, much more mind on mind. He wasn't talking about too much, but he was thinking about the intrapsychic. But what's causing all that intrapsychic pain was external stimuli, external situations. As an older person, when everybody dies and you're the only one left, my dear friend Ray talked about everyone died. His son died in prison, and he had a granddaughter who got addicted to drugs, and then the great grandchild never met him. And that was just too painful for him. It just took everything. He lost everyone. He lost his role. He lost his loved ones. And it was just too painful for him. What the stress diathesis model talks about, if you look at the last bullet, is it refers to a set of suicide-related traits that moderates the likelihood of suicidal behavior in response to stressors. All those other things, but these are lifelong patterns that may have contributed. With number 10 on the previous slide, this notion of this lifelong patterns of what Schneidman called self-destruction, self-destructive tendencies, self-annihilation, those sorts of things. But it's just, we're going to be getting more, I think, in this area in the future, but it's just to understand that our neuropsych colleagues are hard at work on all of this as well. Next slide, please, Ariel. Again, here we are with social determinants. Many of you are very familiar with this, and you've probably seen this, but I want you to think about this. We talk in general, no, again, these are just general numbers, that we think that about 20% of a person's health is determined by the healthcare they receive, and the rest comes out of that ecology that they live in, the environment. If you think about this, what would be different for an older person? And if you look about the socioeconomic factors across the top, education, job status, family support, old people lose their jobs. There's nothing in the world sadder for me than to go into a nursing home and see an older woman who spent her whole life taking care of other people, not having a darn thing to do, and just sitting there bored as tears. Give them something to do, to take care of. I mean, then the notion of family support, income, and this also, if you can read through these, but what do you think is different for older people? Does healthcare play a higher role, a more important role? What about health behaviors? Are they as important when a person's 85 and older? But just to think about social determinants in the context of older people who might be suicidal. Next slide, please. I'm sorry I can't keep up with the chats. I see them buzzing away. Keep them coming in. I will certainly be reading them, and we'll hopefully have some time to discuss some of them. This is for, you can find these in all over the literature. I did a deep dive in the literature, and these are the same things that have been coming up for the past 20 years. Loneliness is numero uno, and you all hit that on the word cloud before. For older folks, grief for the loss of a loved one, very, very often. How many of you know the story of someone, an older couple had been married for 50 plus years, one dies in 2 weeks, 3 weeks, 4 weeks later, the other goes as well. This whole idea of, this loss of a loved one. I mentioned the self-sufficiency, the self-identity that people have. Some people, it's just, I used to visit a man in a nursing home who was the captain of a battleship in the Pacific during World War II. And there's all over his room, there were just awards from him, there's pictures of his crew, and just amazing with the battles that he had been through, and he had all these lives that he was taking care of. And he just sat all day now in a nursing home, this loss of identity. Chronic pain, chronic illness, you're all familiar with that. These are constant stressful living conditions that wear down on people. People with cognitive impairment have higher rates as well, rates of suicide as well. And also, it can interfere with so much. We talked about that constriction. There's no other way. They may impulsively or constrictively not understand that there is an opportunity for help. And that's where we come in our roles, in our organizations. And we have to train our organization to be prepared to do these sorts of things. Financial troubles are biggies too. Next slide, please. These are the chronic conditions you're familiar with, but there's, this is interesting. The National Council on Aging talks about, on older adults, talks about 95%. I think that's a high estimate. I don't know what you think, but 95% of adults 60 and older have at least one chronic condition. That's only 5 out of 100 that don't have a chronic condition. And 80% have 2 or more chronic conditions. Talk about that constant pain and that constant, you want to get out from under that pain. Next slide, please, Ariel. So I'm not going to put a lot of theory in this, but I want you to think about this in the context of what you put in the word cloud. There's 3 models here. The social convoy model, and the idea is as people get older, the people that they lived with and traveled with start to die off and they get dispersed. And then what happens is there's the number of people that are with them in their social network, or they call it a convoy, disperses, and they're all alone. And that's that isolation and loneliness. And then there's this social emotional selectivity theory, SST, the idea that people move through life with networks. Think about the people you work with. If you have a club that you belong to, a religious organization that you go to, a synagogue, a church, a mosque that you go to. And as you get older, everything changes. In neighborhood, if you live in a building or in a suburb, when all of a sudden people say, hey, I'm the old person. I moved in here and I was the young kid with my own family. And now I'm that old person who people are looking at and looking after, hopefully. Who knows? But that network size decreases and it heightens that sense of isolation. And the idea here of the social production functional theory of successful aging, there's a whole literature on successful aging, but the need here is to have confirmation and to feel good about what you do. There's some recent surveys out about, well, I'm going to talk about ageism, but interestingly, a lot of older people feel good about where they are in life. And again, this is just suicidal people. It's not everybody. Most old people now, the majority of older people in the United States feel pretty good about where they are. It's that percentage, those people are on the edge there with the suicidal tendencies that we're talking about. Next slide, please, Ariel. So these are things we can do to reduce risk. We talk about working with the individual, help them. This is where your behavioral health counselors come in, your social workers, your psychologists, your community health workers who are well trained. There's programs here in Massachusetts that we're training home health aides to do suicide screening and interventions because they were the ones that spent the most time with people. And we went through these relationship factors, these community factors. It's so important if you're working in a health center to see beyond the walls and understand where people go, where they go into their environment, where they go into their ecology. And the societal factors, it's a big deal here. There's a lot of cultural, religious, and moral objections to suicide. And that's why a lot of people hide it too. It's also a protective factor because people don't want to die and go against the word of their beliefs. Next slide, please. This is a biggie, and we don't talk about this much. And this is the link here puts you to the WHO, World Health Organization's global report on ageism. They're expanding the notion of ageism. Bob Butler, who was one of my mentors years ago, Bob Butler created this term thinking about older people. But what's interesting is the WHO is thinking about across the lifespan, that young people can be subject to ageism as well as older people. The idea here is that it's associated ageism with our older population that we're talking about today is associated with poorer physical health, poor mental health, increased social isolation, loneliness, insecurity, financial insecurity, loss of identity, and all of those things that lead to premature death. And it's very, very important to think of that as a risk factor. I didn't see that. If you did, I missed it in the word cloud, but ageism is a contributing factor, and it lends itself to that social isolation and that loneliness. Next slide, please. Just think about it, please. Okay. This is a very interesting slide. This is a study that came out of Israel, I think a year ago. And the way to read these, it was the kind of study where they read providers a vignette. And in one vignette, a suicidal individual is younger. And then another vignette, a suicidal individual is older. And what they found that for the older suicidal individual, which is the lighter of the two tan lines on the bar graph on the left, they're less likely to refer them, less likely to treat, and on the right, less likely to refer out. Isn't that interesting? That there's this ageism that they're less likely to take an older person's suicidal ideation or even screen for an older person's suicidal potential, or even address or treat an older person's suicidal tendencies. So understand this notion of ageism. This is some emerging evidence on this as well. Next slide, please. Okay.
All right, we have a few more questions. So you can see the same setup. If you still have Mentimeter open, wonderful. If you need to go back, we will give it just a moment. Again, you can use the QR code or go to menti.com and use the code 8109-0144. So these are going to be a little bit rapid fire, yes or no questions. So we'll give it probably a minute per question, and I'll let Dr. Miramaldi guide us through that.
And I see somebody I'm trying to catch up on some of the chats here.
Yes, we've had several really good questions. We'll think try to circle back to them as much as we can at the end, but if there's any you want to address now, that is also great. We see lots of folks in the Mentimeter. The yes count is currently around 84%.
Thank you for pointing out the failure to include LGBTQIA symbols. In the beginning, I asked you to say when we got it wrong. I appreciate that very much. Thank you. That's a great point. Grieving the loss of a job. Well, not only a job, it's an identity. I talk to people when their spouse dies, they often say, I lost my friend, my lover, and my job. That's big loss, especially when it's very difficult to create new networks.
Peter, Patricia had commented before saying that the 988 line, she doesn't feel is adequately promoted in all communities, and wondering how we can get this more accessible to senior communities in particular.
I agree. I'm going to talk a little bit more about the 988 line. I have links in here. Oh, look at this. I can just hold that for just a second. Let's see how this is panning out. So some of you have made referrals, interesting, to the 988 line. Okay, so I talked to a woman once who was suicidal, an older woman, and her greatest fear was that she would die. She lived alone, and she was very active. And what she was complaining about was the senior centers were all positive, positive, positive. Let's do aerobics. Let's take a trip. Let's go to a restaurant. Let's watch a movie. Let's plan something. We're gonna have like little, but they didn't address the mental health issues as adequately as she would like. And one of the things that really scared her was that she was afraid that she would die alone in her apartment and that she would be dead behind the door for 2 weeks before anyone would find her. And for some reason, this was her greatest fear. And she was thinking about taking her own life so that wouldn't happen, because she was at a very, very advanced age. And, ironically, people like myself would say, well, just get a medical alert or something like that. But this just didn't work. But this was, it may seem irrational to me or you, but this was a driving force for this woman, this enormous, it was excruciatingly painful to think that she would be dead and nobody would know that she died. And she blamed it on the senior center. Now, I'm going to show you a slide coming up here where they're doing a great job with 988 in terms of, you can go online and they will, you can see PDFs, and they make public access. I'm reading this, I'm sorry, I'll do one thing at a time. And public access for a lot of their things. And, they have bumper stickers for the 988 line too, as well. But I mean, if you're in a health center, I'm a strong proponent. You can download so much from the even local or federal sources now. One of the big shticks is elder abuse. Just get something up on the walls in the clinic room, in the break room, someplace that people can see this. 988 should be everywhere, because it affects all populations. We're talking about older populations now, but there was a 2021 study right after COVID, and they found, which was really interesting, that it was just over 90% of people in caregiving roles had severe, very, very serious mental health conditions. And interestingly, the sandwich generation, we talk about young kids under 18 and people who are older, they got older parents and they have young children. They were really suffering, but in the younger groups, almost half were experiencing serious suicidal thought, and that had to do with isolation. Yeah, we have in one of the places that I'm affiliated, Michaela, we have courses on suicide and suicide intervention. We're doing some very interesting work here in the Boston area. Okay. Ariel, do you want to talk about we just saw those responses? Should I just move on?
We can certainly go back. So we had a decent number of folks who have seen promotional materials.
Yeah, but a third haven't, so we got to do a better
Mhm.
job. I hope everybody goes home and puts some promotional material up for the helpline.
So just wanting to review that we had
That's great.
81% awareness.
That's great.
Yeah.
These are great numbers. Thank you. Okay,
All
we
right.
can move on, I think. Here's some resources, and go through these fast. You can download this. The NCECE will have all of this online. These are terrific resources. This is in May, there was another 200 million poured into the 988 Suicide Crisis Lifeline. So this is very important that, these are great ideas, but everything costs a lot of money. So if you haven't already, I would really encourage you to take advantage of what we have. What's very important is that everything, even though all the print material comes in Spanish as well. Next slide, please, Ariel. There's a toolkit. So I think this is where you'll find a lot of the English and Spanish promotional material. I would strongly encourage you to go in there and take a look at it and just delve into it. It can become a rabbit hole, but it's worth the time. Next slide, please, Ariel. This notion of we can come back. I think you're all aware of the 988 helpline. If you aren't, please just do a quick Google search, go to these links, but please try to take a look at it and put up some promotional material in your community, in your workplace. The more we get this out, the better. And again, think about it this way. It lessens that sense of isolation. I can't tell you how many people I've spoken to over the years in a clinical role. They said, I just feel terrible that I want to hurt myself, that I want to kill myself. I'm a terrible person. No, it's an expected reaction. Come on, give yourself a break. That's that constriction. Look what's going on. Look at some of the options. There are better times coming. Things will get better. And this is where these trained counselors are so very helpful. Just give this place a call. It's free. Just dial 988. So it's important. The Zero Suicide program is very interesting. Next slide, please, Ariel. It's a HRSA supported program. And with the zero suicide model, the idea is there's a prescribed approach for health centers to be completely invested in having zero suicide in their panels or their populations. And it's by going through these 7 elements. This in of itself would be an entire webinar, but I would strongly encourage you, and if you're doing it already, you're familiar with this, but this is a very intensive and it requires a lot of buy-in, and it starts with LEAD. Next slide, please, Ariel. Oh, I'm sorry. One other thing about the zero suicide, if you or the people you work with aren't aware of it, please take a deep dive and take a look at it. It's an excellent opportunity to develop and build into your health centers a very comprehensive suicide prevention, treatment, and postvention kind of an approach to suicide that doesn't only remember those caregivers who are suicidal. It's not only the older people, it's the all populations. This is focused at all populations, including youth. Okay, next slide, please, Ariel. This is an excellent resource, the National Action Alliance. Those of you doing telehealth, you might find this video helpful. But if you go onto this website, you'll see it's not just 988, but they provide lots of different resources. Next slide, please. Again, I strongly encourage you to do this. Those of you who are in rural areas, this is a terrific website, the Rural Health Hub. Some of the material is a little bit dated, but they really they work on it. They keep it up to date. It's a terrific program, but they have an entire suicide program here. And you can see right down the side is the introduction, how you get started, program models. They give examples, clearinghouses, how to get it implemented. If you're in a rural setting and you don't have anything going on, and you haven't looked at this yet, please do. I think you'll find it very helpful. Next slide, please, Ariel. And if all else fails, I mean, if you can't find anything, I always encourage people to go to the AAAs, the area agencies on aging. You can click onto this link and just put in a zip code and get connected to the AAA in your area. I was recently in another state and found 28 AAAs in that state and just randomly called a few to ask them. I told them what I was doing and I said, you know, what do you kind of, and I was very, very impressed with how they were connected to local resources. So if somebody's feeling isolated, you may be able to get them connected with some sort of a program, a day program, a senior center, a companion program. But that's where the AAAs come in, and they're very local and very regional. This is all funded by the Aging American Act. So I think it's really important to take advantage of this. Next slide, please, Ariel. And here, this is a terrific website. It's the International Association of Suicide Prevention. I think that this is really worth looking at. And the boxes along the bottom, the rectangles along the bottom, are all additional resources for suicidal individuals. And they're very, I took a deep dive into all of these, and this will help you with some language as well, as will the next slide, please, Ariel. Oh, I guess it's not there. Let's talk about, you said, I know where it is, screening instruments. How many of you screen? Next slide, please, Ariel. So we talked about social determinants of health. Many of you are probably using the Prepare screening. What I really like about it is that a lot of folks have it in their health record, electronic health record, and it's in all these different languages. Next slide, please, Ariel. And it's a way to compare. It's a good metric. This is probably the simplest measure of loneliness. 3 questions. And if you go to the next slide, this is how you score it. It's very straightforward. And even if you're not in a health center, if you're in a community area even without a health record, you can do this on paper, pencil. You can identify who's lonely with these, if that's helpful to you. And then hopefully you'll have resources in place to address that. Next slide, please, Ariel. Many of you probably use the GDS, the Geriatric Depression Scales. It's evolved over the years. And we've gone from the 30 item to a 15 item. Now there's a 4 and a 5. If you go to the next slide, we see there's some questions about the effectiveness of the 4 and 5. And if you're interested, here's a link to a recent article. Next slide, please, Ariel. Here's the PHQ-9. I'm not going to spend time on it. Most of you are familiar with it, but I will tell you this. I can't, more times than I can remember, older folks, have said to me, oh yeah, they ask me those depression questions all the time. I just lie because I don't want to have to go to another doctor. I don't want to have another appointment. I don't want to have another prescription. So I always question these, but they're better than nothing. And I think that it's excellent to use them. Next slide. What we're doing now is we're trying to get more detailed information. We're trying to develop severity measures for depression. How severe is the depression? And this is a public access. You go here as the APA has this available for comment. Next slide, please. The S-suicide screening questions. This is a terrific a visual. It shows you we do a basic screening, and then it's followed by an assessment, a suicide assessment. Now, typically, everyone in a clinic or a setting should be able to do that brief screening, but the assessment is to determine the lethality. And that may be somebody who's special training, and they may be a clinician. And what you're trying to determine if the person needs a full mental health evaluation. Next slide, please, Ariel. These are the kinds of language, too, that you can see on the side there. This is a widely used Columbia suicide screening tool. Again, this is a really good measure that if somebody starts talking about suicide, and if you're in a setting where you want to measure things, I would encourage you to take a deep dive into this, and you can see how easy this is to score. Next slide, please, Ariel. Do you have coding in your center if you're in a health center? I notice a lot of you are not, but if you are, are you familiar with these ICD-10 codes? And this is a really great way to track, and it's a great way to train staff, and it's a great way to leverage resources, and a great way to develop community relations and resources in the local community outside of the walls of a health center. Next slide, please, Ariel. It also gets people paid. This is a very important area of suicide that I hope you're all aware of. It's postvention. Next slide, please. And postvention is really includes everyone, survivors, family, friends. My student that I'm working with now is talking to the parents of decedents, and these are compelling interviews that she's analyzing, doing a tremendous job on these, but has the dual purpose of assisting survivors through the grief process, and it helps with future preventive efforts. And again, you can call the 988 Lifeline, and they'll help you with postvention issues. Next slide, please. You can read these. These are the goals of postventions, but the idea here is that it should normalize the anger and minimize self-blame. Most survivors feel tremendous guilt. And think about that enormous, excruciating psycho pain that Schneidman, the psychache that Schneidman talked about. A lot of survivors feel that, and they need help. So it's very important to follow up. And these should be in place before the suicide. And so if you're in a health center, if you're in a community setting, please think about, what are we going to do if somebody that we're affiliated with, it could even be a staff member, what are we going to do if somebody kills themselves? What do we have prepared for postvention? The time is now, right now, to prepare for it. Next slide, please. And again, here's the Rural Health Center, terrific overview, Rural Health Hub. Those of you in rural areas, I've used this in some of this material in urban areas as well. So I think it's worth taking a look at. Next slide, please. This is very important. The shame and guilt that people feel, the traumatic impact it has on families and friends. We think about this a lot with young people, but it applies to old people as well. But it's that ripple effect that's important. If you're working in a senior center, if you're working with populations, very specific populations, it's really interesting, how tight-knit populations can be, different cultural groups, LGBTQIA groups, how these different groups have these tight networks. And if somebody in that network dies, you better be really careful because of the ripple effect. And these ideas travel fast. And then finally, I just want to say, as a clinician, if you're a provider, if you're a worker, if you're working in a crisis center, a community resource center, take care of each other. Be prepared. Those postvention services should also include clinicians and staff. That's very, very important. Next slide, please. I rushed through this because I saw those chats lighting up. How can I help by answering some questions?
Yes, I can give you a couple of questions that we haven't addressed yet, but I encourage folks to keep them coming. I'll start with actually one that just came in the chat. Is postvention for survival people or suicide survivors themselves? So kind of saying who is
Both.
postvention? Yeah, both.
But people who attempted suicide are still suicidal, and those are the people that should be receiving it, some sort of treatment or support.
Sure.
But when we talk about postvention, it's most often in the literature, we're talking about people who have survived the death of a friend or a loved one.
We had a question around depression screening. The question is, do you think explaining the reason for the PHQ 2 or 9 or any of the numbers can explain and explaining their primary care provider can help, would make a difference? I do think it's just an interesting topic in how we're making these validated screening tools an opportunity to discuss things with patients. As you said, you've had many a conversation with older adults who know the drill when they're answering questions, but that's not really getting to the root of things.
Right. So I've also spent a lot of time observing teams working with older people, going to geriatric clinics and places like that. And, at the end of the day, even with someone in the room observing, they're so stressed out for time. I mean, it's so unfair how pressed we are to get patients through that most times by the time you do that screening, it's just so rote and it's important. So yeah, perhaps we could explain why. But I think we often forget how wise older people are. They have a lot of experience. But I think don't let me give you the wrong impression, please. I think it's absolutely very important to do a depression screening. If we didn't have those data, we wouldn't have services. Those data are feeding into the 988, the funding for the 988 Health Line, for example, or the NGOs or the nonprofits that are providing depression or anxiety screenings lead to services for those people. It's unethical to screen if we can't provide the service. So the more we screen, the more we'll have opportunities and funding for those services.
Absolutely. We have another question or two, but because we have just a handful of minutes left, I do want to just mention that when you all leave the webinar today, an evaluation will pop up. We'd love to hear your thoughts and do want to encourage you, if you have questions that you're sitting with, concerns you're sitting with after this session, feel free to contact Dr. Marimaldi or us at the NCECE inbox. And yes, you will have access to the webinar recording and slides. And feel free to keep those questions coming. I do want to mention one that we got early on that was from a student at the University of Florida who's interning for SAMHSA and involved with their local 988 center. They would like to see the study of suicidology as a course at their university. And from your perspective, do you foresee such courses as part of a higher education curricula? How could someone like themselves go about pushing for a course to be available for students?
Absolutely. Write to your educators, your deans, your student groups. Students have a lot of power in education. Students have a lot of power in government. It's very important to, yes, I think it's a great idea. And as I mentioned earlier, we have in one of my institutions that I work in, we're moving in that direction a lot. I mean, there's a lot of interest in aging, just the population shift. Go ahead.
Oh, no, I just got to mention, I think the last kind of quick question was an interesting one, more about how the language we use around things. Obviously, in many areas, we see a shift in the terminology that we're using. And one of those is the idea of commit suicide. So there was a question on, are we saying that anymore? And I know that some guidelines lean more towards a person who died by suicide or lost their life to suicide. That person first sort of language, but curious if you had any other insights into that.
Yeah, I'm looking at Teresa wrote, it's no, is it no longer called commit suicide? No, we can say suicide. We can say, took their life. How does the language, what kind of stigma is perpetuated by the language we use? And I think a lot of this, we can talk in generalities, but a lot of this is local. And when you go into different languages, for example, it has different contexts.
Absolutely. And thank you, Lindsay, for sharing that in the chat. We hope that we've gotten to almost all of your questions today. Again, if there's something that we missed, we are saving the chat and we can try to make as many resources available in our follow-up emails to you. But again, please take a moment to give us your feedback, give us your ideas for future training opportunities. And we hope that we'll see you back in another webinar or learning collaborative. And we very much thank Dr. Marimaldi for all of his insights and resources shared today. Again, we will follow up with all of these session resources for everyone who registered for this learning activity. So out of respect for time, we'll close it out for now, but we would love to continue this conversation in future opportunities. So thank you so much for your engagement and your questions and your insights. Take good care, and we hope to see you soon.
Can I just say, I saw that in the chat, completed suicide, that's an emerging term that people are using as well, and it's sort of regional. But thank you all very much. Please go out and educate people, put up the 988s. Thank you.
Thank you. Take care, everyone.